Hello and welcome again to Cardiac Imaging Agora. In this session, we will tackle the issue of identifying hibernation on cardiac PET. We will go through the same steps we use in every reading session, except for this time after we get to the point of identifying perfusion defects or the lack of perfusion defects on the rest and stress images. We go to review the FDG metabolic images. So we'll follow the same laundry list of steps, of checklist of steps we use to read every other different cardiac PETs study. So we start first with the transmission and emission images for co-registration. And again, you can see here good registration on the rest images of the perfusion and CT images. And we right away see here a large right-sided pleural effusion identified. We go to the stress images. We do the same process. Co-registration seems to be okay. No issues with that. And finally, we go to the same process for the co-registration of the FDG images with the heart. So we have the FDG metabolic images here registering with the heart. And you can see here the liver uptake with the FDG, as well as an uptake in the pericardium here, identifying a small pericardial effusion that the patient had. Then the next step is to adjust the reconstruction planes. Again, as usual, we go through this step by step. We make sure the borders or the margins of the heart are identified properly for both the rest images on the bottom and the stress images on top. We then do the same process for the FDG images. Very often you have to move the area of interest from somewhere in the GI or lung or liver and put it over the heart. You limit your area of interest here to avoid spillover from GI activity into the processing of the images or into the, especially if you're trying to reconstruct these on a 17-segment model. And you go on and you pull up the processed images. So as always, I don't look at the FDG images till later, but I look first at the rest and stress images, perfusion images. So you have the rest perfusion images on the bottom, stress images, normal display. And you can see right away, you can identify, at least on the short axis images, a significant perfusion defect involving the basal inferior wall, inferior septum, similarly seen in the stress images here. Again, you can see it here in the vertical long axis. Rest and stress images, we have a perfusion defect in the inferior wall extending from the base all the way to the apex and involving part of the inferior septum, as you can see right here. Again, you should not be considering diaphragmatic attenuation. These are PET images. All these images have attenuation correction built in. We go on to look at the polar maps and how to interpret these studies on the polar maps. You can see here rest images, 17-segment, standard polar map, stress images, very similar defect in the rest and stress images, as we said before, involving the inferior wall and the basal inferior septum with no significant reversibility, maybe minor reversibility, but not significant to call. The next images here are the FDG images. I always, to simplify my life and make it easy, I get rid of the stress images and just look at the rest images and the FDG images. So here are the rest images now shown on top and the FDG images on the bottom. And right away, you can see this puzzle piece that was missing here in the inferior wall in the perfusion images now is filled up by FDG. Again, you can see it best here in the vertical long axis. You have an inferior wall defect that fills beautifully with FDG, indicating a perfusion, FDG or metabolic mismatch, indicating again the presence of hibernation. This is the hallmark of hibernating myocardium on FDG images when you compare the rest images with a perfusion defect with increased uptake of FDG, preferentially in the area of the perfusion defect. Here's a 17-segment model, how we display this. These are the rest images here with the perfusion defect well seen. And these are the FDG images. If you can actually transport this area of uptake of FDG up to here, you can see that this is fits almost perfectly. So again, rest perfusion defect was mismatch and increased FDG uptake in the same area, indicating hibernation. And then I put all the images together, so stress on top, middle images will be the rest, and the bottom is the FDG, just for display. And these are the images we save in our system for posterity. So rest, stress, FDG on the bottom. Again, we can see this stress, rest, and FDG, and again displaying the intense FDG uptake in the area of perfusion defect on rest and stress, indicating again hibernation. The next stop here is to look at the histograms for the gated images. This patient seems to be in some kind of atrial fibrillation. You can see on rest images here, on the stress images, there is wide variability of the histogram, indicating the presence of a probably variability in the heart rate during the acquisition of the images, most likely atrial fibrillation. These are the gated images here. Again, this is a patient with severely reduced ejection fraction. You're talking about ejection fraction in the mid-20s here, very dilated ventricle, global hypokinesia, probably akinesia in the inferior wall. Again, the contours here tracing or tracking beautifully the walls of the heart. Then we go to the Dyssynchrony analysis. On the right-hand side, as in prior sessions, I've showed you a normal Dyssynchrony analysis for a normal patient, rest and stress. And here we're dealing with very dysynchronous ventricle. None of these segments are contracting or reaching peak contractility to generate an ejection fraction that's normal. Again, you can see it in rest and stress with probably poor dyssynchrony. Then we go to myocardial blood flow. We did not report the myocardial blood flow on this due to the severe left ventricular ejection fraction. It's the policy of our lab not to report it in patients with an ejection fraction less than 40% or with prior bypass surgery till we get more data about these patients and how to interpret the data. The next set of images here will be the CT images. We review them again for calcification of the coronary arteries, presence of extracardiac things, and here we can focus your attention to the pleural effusion present in this patient. Then we have to generate the report and put all this thinking we did through the and translate it into a meaningful report. We tried to figure out why we're doing this study. So we're doing this study to assess for ischemia and viability. This was the reason it was ordered. We record the dose that was given for both the rubidium at rest and stress, the agent we used for stress, regadenoson, and then the FDG dose and what was the blood sugar during the FDG administration. Then we fill this clinical sheet here. This is a patient who has history of coronary artery disease, prior PCI to the RCA in 2014. Presenting right now with chest pain. This patient is an atrial fibrillation, as you can see here. This is the data on what happened during the stress test. Again, this patient started with a mean heart rate of 72 or 77 during stress, and you can see the blood pressure dropped during stress, indicating that the regadenoson we gave probably worked. Then we go to fill the part related to the ejection fraction for the left ventricle and right ventricle. This is severely dilated ventricle, as you can see here, with a very poor ejection fraction. And also, if you look here carefully, you can see this right ventricle has poor contractility and is significantly dilated, and we record that right here. Then we move to the page to report the perfusion defects. As I showed you before, this is how we call the perfusion defects. There was no ischemia to see here. We did not call any scar, given the fact that this area of perfusion defect reflected hibernation, so no ischemia, no scar, and then we called hibernation in the territory of the RCA. So to call hibernation, we call it on a scale like this. So these are the images of the FDG here and the perfusion at rest, and we called hibernation. 1 we call viable, 2 scarred, as suggested by the American Society of Nuclear Cardiology guidelines of calling hibernation. So we have viable or non-viable, which is scarred, as a scale of 1 to 2. So if we're dealing with a patient for sarcoid or other things, then we use this field of normal or abnormal. But in this instance, we're dealing with a viability issue, and then we call it viability. So we have 4 segments of viability in the inferior wall. So this is how the final report was generated. We have an abnormal study. There is no evidence of ischemia or scarring. This patient ended up having hibernation in the territory of the RCA. The ventricle was severely dilated with severe LV dysfunction, and the right ventricle had moderate dilatation with moderate dysfunction. Again, a right pleural effusion was noted, and this is a high-risk scan. So this is the report that the referring physician gets. Very comprehensive report. Now we go to the story with this patient. This is a patient who presented actually with cardiac cath and a prior SPECT performed, and the reason nothing was done about the finding here on the left-hand side on the cath is because the SPECT that was done on this patient showed a fixed perfusion defect in the RCA, and the patient was thought not to have any area of ischemia to target with angioplasty. So this was the RCA on this patient. However, as you can see from our analysis here, this area that was thought to be or misconstrued as a fixed defect and scar on a prior SPECT, and even with the PET here, if we did not do the FDG images, we would have misconstrued this as a fixed defect with nothing to target, was found to be hibernating. So this patient went on to undergo an angioplasty and stenting of the RCA, and this is the final result on the right-hand side here. This is a huge vessel, as you can see here, supplying almost all the way to the LV apex. Thank you for listening again and watching this. Again, this is a highlighted case of the importance of hibernation, evaluation, and not stopping at the fixed defect when you see it on rest and stress images. If you have a clinical suspicion that the patient is still symptomatic, or there is an area of that you can target with a percutaneous intervention, especially in patients who are symptomatic, I think proceeding with the hibernation study with FDG is essential to arrive at the right diagnosis. Thank you.